patient. So I'm going to be focusing more on explaining why we ask the things we ask, what the history means, trying to branch out and say, like, if something else were present, what would you think? But in the future, for the next case, you're not going to really know anything about the patient. And so you're going to be asking me as if I were the patient or the family member of the patient. So it'll be a little bit more difficult, but I think the learning will be a bit better. So, all right, I think we have everybody here. Perfect. Okay, so our patient is a 78-year-old female who has progressive chest pain and shortness of breath over the last 1 to 2 weeks. She's alert and oriented to herself and to the time, but not to where she is or why she's there. So the daughter's present and she's helping with the history taking. So she's coming in with chest pain and shortness of breath. So so with the chest pain and shortness of breath, Dr. Ivan, what would you want to know about the chest pain?
First, I would like to know where it's localized, what activities worsen the chest pain, make it better. I would look at her history. So based on her age, I would already say that she is at an increased risk for respiratory infection. So I would first start with looking at the lungs.
Okay. So would you do that because you think it's an infectious process, or would you do that for every patient that came in with chest pain?
No, just for this specific patient, not for every patient in general, no.
So, yeah, so when we look at somebody with chest pain, if they have a lung infection, that's not going to kill them right away, but a heart attack will. So you always have to triage and see what can potentially kill them and take care of that first and see if that is actually going on, and then after that go from there. So you mentioned where it was located. So for her, it's located on the right side of the chest, and it radiates to the right shoulder. Does that ring any bells for you? Does that mean anything to you?
That would be my first indication of possibly a heart condition, and looking at her chart, she does have history of coronary artery disease and other heart conditions as well.
Good. So typical chest pain is usually substernal and left-sided. For her, she's on the right, but what we know is that for elderly patients and women especially, the typical chest pain isn't really typical. So good. You always, especially with her history, you want to keep an open mind of that. Perfect. So 2 weeks ago, she had a sore throat, congestion, and a slight cough. So Dr. Bryant Mombeni, does that ring any bells for you? Does that mean anything to you at all? Okay, so let's go. If your mic isn't working, that's okay. You can just comment that it's not working, and we can go from there. So Dr. Girish, and I apologize if I mispronounced your name. So she had a sore throat, congestion, and slight cough. That improved, but her cough lingered. Does that mean anything to you? Does that make you suspicious for anything in particular?
Maybe she stated that she had an infection or she was ill a few days ago. So maybe that's still like in her system or lingering around. So maybe that's, a concern.
Yeah. So when you have a sore throat, congestion, a little bit of a cough, that sounds like a viral process. That sounds like a viral cold that all of us get. And so that's definitely important to keep in mind, because viral illnesses in general can always, they usually will go away on their own, but sometimes you have a superimposed bacterial infection on top of that. So it's always important to keep the previous illness in mind. But aside from a superimposed bacterial infection, is there anything else a previous upper respiratory infection can cause in terms of like cardiac issues?
I'm not too sure.
Okay. Anybody want to help her out? Does anybody else know?
What my group and I were discussing essentially is that as far as viral infections go, it is consistent with pericarditis, and then as well as pleurisy. So, but I believe it's more consistent with the first option, given the fact that she had a cough and a fever for a long time, which may indicate that she has an inflammation in the pericardium.
Okay, good. So that's good. So the upper respiratory infection that causes a pericardial inflammation causing pericarditis is usually Coxsackie virus. And so that's a very, very good point. So you always do want to keep that in mind, especially if she's complaining like she did that her chest pain is worsened with the cough. So good job. Okay, so so she would normally walk around the block daily with her dog, but she's telling her daughter that she's too sleepy and doesn't want to go. So Dr. Horder, what does that make you concerned at all about any cardiac issue?
Yeah, I was thinking decreased blood flow to possibly her brain or just in general, and also decreased oxygen levels to the brain and the body.
Making her sleepy?
Yes.
Okay, potentially, yeah. So let's say she was saying that when she walks, she doesn't want to walk because it hurts. Her chest starts to hurt. What would you be concerned about?
Possible heart attack or the angina.
Yeah, exactly.
Yeah.
So it's that chest pain that gets worse with exercise or activity, right? And it gets better with rest. Now, let's say that she is not able to walk because she gets tired, but she has no chest pain. She just gets short of breath. What would that be concerning for?
More the lungs.
Okay. What about the lungs?
Shortness. Possible inflammation or something blocking. I know in the x-ray you could kind of see like fluid in the lungs or something going on in the right lung.
Okay. But aside from the x-ray, is there anything that you know about that causes shortness of breath as you walk, and once that process gets worse, it becomes even harder to do activity? And it's a little bit of telling me what I'm thinking, which is always difficult, but take a stab at it if you can. And if you don't know, it's okay.
Yeah, I can't think of it right now.
It's okay. So let's say Dr. Justin Pagan.
Yeah.
If I tell you that her legs are also swollen, what would you think of?
If her legs are swollen, could she possibly have like any clots in her leg or edema or fluid buildup?
Possibly, but so if her legs are, if one leg is swollen and it's red and inflamed, you can think of a DVT that causes a pulmonary embolism. But if both legs are swollen, you're now talking about fluid backing up. So with fluid backing up, that's more of a heart failure problem. So with heart failure, you aren't able to exercise as much because your heart isn't pumping the blood as much as it should be. So everything's backing up into the lungs. And as soon as the fluid backs up into the lungs, you're not able to do as much exercise because that fluid makes it harder for the oxygen to perfuse into the blood. And so you end up having lower exercise tolerance, but it doesn't necessarily cause pain. Does that make sense?
A little bit, yeah, it makes sense.
Okay. Okay, so if we were thinking heart failure, we would be thinking more of that swollen legs, progressive shortness of breath, but no real pain. Okay, perfect. So as she continued to cough, her chest pain worsened. The cough was non-productive. So Dr. Amin Khan, with that history that her as she coughed, her chest pain worsened. Is there anything that you can think of that can cause that type of chest pain?
I'm not sure, but maybe I read that when she was sleeping, it was also worse, and she couldn't sleep because of the cough.
Mm-hmm.
Maybe due to her sleeping position, or something like maybe something with her lungs, like going against the chest.
Yeah. So potentially, if you had something like pericarditis, or if you had some type of pleural inflammation, whenever you cough, you're going to have some pain there. But aside from inside the chest, what else is in the chest area that can cause pain when you cough?
Could it be the lungs, or like, I guess I'm seeing diaphragm inflammation? So maybe the diaphragm for lungs.
Diaphragm potentially, yeah. But Dr. Darul mentioned it. So the ribs, right? So and then Justin as well. So when you have inflammation of the ribs, and more specifically the junction between the cartilage of the ribs and the sternum, you can have that pain. So typically when we breathe, we're breathing very slowly. So like in and out, we're not aggressively pushing things out to try to cough something up. But when we're coughing, we're being more aggressive. We're using more of our muscles. And so you have overexertion of those muscles and inflammation of that cartilage, causing something called costochondritis. And so costochondritis isn't necessarily dangerous, but it's something to keep in the back of your mind, because in the end, if all the workup was negative and she was just having chest pain when she coughs, then you can give her some anti-inflammatories and she'll do better. Okay. So all right, Dr. Sanchez. I told you that her chest pain was located in the right lower chest, parasternally, and radiates to the right arm. Can you explain what that means? Let's go to Dr. Destiny. Can you explain what it means when I say that her chest pain is located in the right lower chest and radiates to her right arm?
So for that, like, are you asking like what it means to me, or just like what it means like in general?
What it means to you, like what does it make you suspicious of? Like, what process is going on that's causing that pain?
Well, I feel like it definitely wouldn't like occur to me first that it's the heart, more like friction that's causing the issue. So it's not necessarily like we discussed before, it was probably what's it called? Like the one where it's the friction between the heart and the lung.
So like pericarditis or like pleurisy, yeah?
Yeah. So that's what it would alert to me.
What about radiating to the right arm? So
I'm not really sure, because
okay, that's okay.
Yeah, I know, okay. Like if it was radiating to like the back, then that I remember that had to do with aortic dissection because of the patient. But for radiating, I don't know.
Okay, that's okay. So Dr. Danny, can you explain what you mean by referred pain?
Hi, so I was just saying referred pain as in like, well, we talked about how the diaphragm could be affecting that. So the pain from the diaphragm, like when you inhale and exhale, it causes pain just in that area, I guess.
Okay, so you're right about the diaphragm, but what is it about the diaphragm that is causing referred pain, and why is it going to the right shoulder?
I'm not sure. Does it have something to do with like the spine, or I'm not sure.
Close. So, Dr. Larkin, explain what you mean by the phrenic nerve.
So like the phrenic nerve is what innervates the diaphragm, and so that's coming from C3, C4, C5, around there. And that's like the same area that the branches going to like your brachial nerves are coming from. So it might be that like it's being referred from those.
Beautiful. So the phrenic nerve, the way that we remember it in med school is 3, 4, 5 keeps the diaphragm alive. So the phrenic nerve innervates the diaphragm, but also, just like you said, it goes to the right shoulder as well. And so if you guys think of like testicular pain, if somebody's hit in the testicles, you feel the pain in the abdomen, right? Because that's referred pain. That's where the nerve fibers originated from. And so same thing with a laparoscopic surgery, when they insufflate the stomach and they put air in the stomach, so they can do the surgery. Once everything is out, patients typically complain of right shoulder pain because of the diaphragm inflammation or irritation from the air that's trapped in there, and it gets better after a few days as your body reabsorbs the gas. So the right shoulder pain is most likely because of referred pain from diaphragmatic irritation. So YouTube is saying difference in pressure of each lung maybe if it's damaged due to recent infection. I'm not sure what they mean by difference in pressure. Phrenic nerve was correct. CAD is potentially an issue, especially given her history, but we'll get into that a bit more. And yeah, so a right arm can still trigger should still trigger you to think of possibly coronary artery disease given her history. So always good to keep that in the back of your mind. Okay. So in the morning, the daughter says that the mom appeared more confused and she refused to eat. So Dr. Ono, why did I tell you she was more, so why did I focus on her refusal to eat?
I'm not really too sure, but I know that if she's not eating, then she's not getting the proper nutrients, which would probably make her more tired.
Good. So that's definitely a possibility, but she has dementia, right? So how do we know that this is not just her dementia being just at her baseline, and how do we know that this is something new for her?
Oh, because it says like refusal, so it's like it's out of the norm for her. It's not
exactly. That's perfect. It's out of the norm for her. So a lot of times we struggle with, is this the patient's actual baseline or is this something new for her? And for her, she eats normally, and so she's refusing to eat now, which is not normal for her. So that tells us that there's something going on. Same thing with her daughter saying she appears more confused. Because a lot of times it's easy to say, oh, she has dementia, that's just her baseline, whatever. But if the daughter says that she's more confused, we need to take that seriously. So it's really important to pick out those clues in the history, because if you don't, you can potentially miss something that is dangerous. And so if a patient with dementia comes in, the first thing that I look for is actually a UTI, because a lot of them will have UTIs, and that causes confusion. So very good job. Okay, so let's go on. So let's take, let me see here, sorry about that. Dr. Chelsea, I told you that she denies chills, nausea, vomiting, abdominal pain, hemoptysis, loss of consciousness, palpitations, and anosmia. Is there one thing in that review of systems that sticks out to you more?
Palpitations, because wait, sorry.
So she's denying all of this. So if she denies palpitations, what does that mean?
I mean that because she doesn't. I mean because
I mean, from her history, we can say that she's probably having a heart attack because of all the chest pain and the radiating to her arms. But if she's not, but she doesn't feel like she's having increased heart rate, so that could be something that's like kind of sticking out.
Yeah, so palpitations, a lot of times people can be tachycardic and not feel palpitations. A lot of times you'll feel palpitations more when you have an arrhythmia. So it's important to know that she doesn't really feel it. But let's go to Dr. Martin. You're saying anosmia. Why is that?
I was saying that because it would be loss of smell, and we can think about the coronavirus and COVID-19, and so if they had it, then they would maybe have a loss of smell.
Perfect. Yeah. So anosmia is super important, especially for you guys that are working as a scribe. Every patient that I saw recently that had anosmia had COVID. So be very careful with that. If anybody tells you they're not smelling right, just be cautious. So perfect. And then Dr. Gowrie, is that how you pronounce your name?
Yeah. Okay, so I said hemoptysis because that's coughing up blood, and you would be worried of a lung condition, I guess, like TB or possibly even lung cancer.
Okay, good. So why do you cough up blood when you have lung cancer?
Is it because of the vessels, and like the tumor disrupting the vessels?
Yeah. So when you have lung cancer, it's an abnormal growth of cells, right? So you have vessels that grow into the tumor, but they get disrupted as the tumor grows, and you can start bleeding into the airways, and it causes irritation, causing you to cough up blood. So whenever somebody has hemoptysis, there's two things that I usually worry about: cancer and TB. TB is tuberculosis. You definitely don't ever want to get tuberculosis. The treatment for it is very long and can cause a lot of issues. But it can be pretty contagious if they have active pulmonary TB. So the hard thing with tuberculosis is it's one of those diseases that can mimic a lot of other diseases. So those are the two things I typically think of. So someone on YouTube is saying inflammation in the brain can cause loss of smell too. There's a lot of things that can cause loss of smell. Anosmia typically is not a very common symptom. So because of where we are right now, that's why it's really important to associate anosmia with COVID, just for your own personal protection and protection of your staff. Okay. Perfect. Those are the ones that I had picked out for that were more important. So Dr. Downs, Emily Downs, are you here? Let's go to Dr. Spence. So I told you a little bit about the work history of the daughter, son, and son-in-law, and that she lives at home with the 2 grandchildren. Can you think of any reason why I gave you that history?
I think that maybe it's because it lets you know that, yeah, she can be partly independent, but not enough for her to live on her own. And there are probably some things that, or especially because of her dementia, she probably shouldn't be living alone 24 hours a day.
Yeah, and so it tells us 2 things. One, I think in the case I had mentioned that she was pretty independent of her activities of daily living. To her dementia, it seems like it wasn't too bad, but it is a concern if she has dementia and she's at home by herself, especially if she's in charge of her own medications, right? Because is there any medications that she was taking that you'd be concerned about if she took too many?
Maybe her hypertension one, but I'm not exactly sure.
Yeah, her hypertension one, honestly, all of them, if she took too much medications, all of them can cause problems. The ones that would cause confusion, her hypertension meds, if she took too much of it and her blood pressure went down, then yes, definitely. Dr. Girish mentioned glipizide. Dr. Girish, do you want to explain that one a bit more?
Yeah, I was actually like looking at the side effects of glyphosate, and it said that it can lead to the patient being more confused. So that could, potentially be something to think about if she's alone.
So why would that cause confusion?
Not sure. No.
So what is glipizide used for? Do you know?
No. I was just reading the side effects.
It's okay. So glipizide is used to lower blood sugar. Yeah. So Dr. Larkin, do you want to take that one?
I just know that it lowers blood sugar, and so like I don't know if it's too low or if she forgets to take them and her like blood pressure raises, she could get like gosh, what is it called? Like acid or ketoacidosis. Yeah. So like that could cause confusion.
Yeah. So that's one side of it if it goes too high, but the other side of it, which is if she takes too much of it and her blood sugar goes low, then now you have hypoglycemia where your blood sugar is super, super low. You're not able to actually give the brain enough glucose. The brain only uses glucose to function. And so if it's too low, you're not going to be able to think and be aware as you potentially would. So yes, exactly. So hypoglycemia can cause confusion as well. The diuretic she takes can decrease sodium levels in the blood, cause confusion and fatigue. So yeah, so the diuretics are not for diabetes, but they are for her high blood pressure. So that's the hydrochlorothiazide that can cause low sodium and can cause confusion and fatigue as well. And then the other part of that is if she's living with other people, she can potentially be exposed to COVID, just like as somebody on YouTube had mentioned. Maybe her son-in-law brought it from his work, but yeah. So let me see here. Okay, so when she comes to the emergency department, let's go to Julia Pearson, Dr. Pearson. Can you interpret her vitals for me? So she has a blood pressure 158/93, a heart rate of 110, respiratory rate of 24, temp of 100.5, O2 sat of 93 on room air.
So the blood pressure is elevated, but I don't think enough to be super, super concerned about it. And the heart rate is also a little bit elevated.
Mm-hmm.
The respiratory rate, 24, is pretty high, I think. Normally it's like 16 to 18.
Mm-hmm.
And she does have a bit of a temperature, probably from her illness in the previous weeks. But her oxygen is really low. I think it should be at least 95%. The 93% is a little bit concerning.
Yeah. And so is there, looking at her vitals, do you notice any pattern? Do you think that there is any specific syndrome that she might be having? It's a harder question, so.
This kind of indicates something with the lungs to me because of the low oxygen levels, and maybe her heart and lungs are working hard to recirculate any oxygen that's there.
Yeah, good. So so her body's definitely working harder. She's having issues breathing, and so she has a high heart rate. Her temp is elevated. Her respiratory rate is elevated. When we look at these vitals, a lot of times you're trying to see, is she septic or not? Does anybody know what the definition of sepsis is? And it's okay if you guys don't. If you do, you can always just call out.
Infection?
So it could be infection, yeah. So sepsis can definitely be caused by infection. But the definition of sepsis is two parts. One is the systemic inflammatory response syndrome, or SIRS. What we look at is a elevated heart rate, elevated respiratory rate. You'll have an elevated temp, and then you will also have an elevated white count, which she actually fits really well. And once you have SIRS, and if you have a source for your infection, now you're septic. So all sepsis and SIRS is your body has an overwhelming inflammatory response to something. And so when that happens, all of your vessels tend to dilate. you can have a decrease in blood pressure, which for her it's actually elevated, and so she has a septic or inflammatory response picture. But just like Dr. Larkin is saying, how do you know what the source of sepsis is? You don't know until you try to figure out what her diagnosis is. And so for her, we'll kind of get to what her source may be. And yeah, somebody on YouTube is saying sepsis occurs when chemicals release in the bloodstream to fight an infection, trigger inflammation throughout the body. Yeah, exactly. Okay, so let's move on. So Dr. Verma, is there anything in tell me one thing in her physical exam that stuck out to you?
Looking at her physical exam, like one thing that stuck out to me was that she said that when she used to go around for walks on around the block, but then she reported that her daughter reported that it was decreased recently. And I feel like through her physical exam, I feel like that might be a concern for just myocardial ischemia, just because she can't do as much without exerting herself. And the chest pain in the right lower chest, when you look at the chest x-ray, it shows that there's some sort of fluid or inflammation buildup, which makes me think that there might be a bacterial infection, which could lead to pneumonia, among other things.
So what in her physical exam would clue you into what you're saying?
In her physical exam, give me a second, I'm just
it's okay.
Looking at it again. The physical exam part where she said that she had the sore throat, congestion, and the slight cough.
So more so when you examine the patient yourself. So if you look at the lung exam, the respiratory exam, so where it says tachypnea, is there anything in there that kind of points to some type of fluid issue or what you're talking about with potential pneumonia?
Wait, what did you say it was again?
So in the respiratory exam, she has tachypnea, increased work of breathing, symmetrical expansion of the chest, mild crackles in the right lower lung fields. So any of that kind of point to a pneumonia type picture? Because you were mentioning that you think it might be pneumonia.
Yeah, I think that if it was pneumonia, the physical exam, given that she has the increased work of breathing, that could be due to the fact that there's some sort of fluid or something blocking blocking up the lungs, which might make it harder for her to breathe. And the crackling could be due to the fluid as well, because I think it's just that the alveoli in the lungs can be inflamed and filled with pus, which might kind of lead to that. I'm not really sure.
Good. Yeah. So the crackles can be indicative of pneumonia. It can also be indicative of just fluid. So if you have fluid backup because of heart failure, you can have this crackling type sound. So good job. So let me see. I lost. Oh, so Dr. Karan, you mentioned her mucous membranes. What are you concerned about there?
So it said that she had tacky mucous membranes. I forgot exactly what that meant, but that was an issue that stuck out to me.
Good. So tacky mucous membranes just means that they're a little dry. It kind of feels not so much sticky, but I don't know how to describe tacky, but they're a little bit dry. So what is that potentially a sign of?
Possible dehydration.
Perfect. Okay. And so let me see. So Dr. Aisha, you mentioned tachycardia. Can you explain that a little bit more?
Yeah, so tachycardia is consistent with her heart rate being higher, and I'm pretty sure it's associated with pneumonia and pulmonary embolisms, because your heart is working harder in order to get the oxygen to the places in your body that need it.
Okay, good. So tachycardia is always a sign of pulmonary embolism. So somebody comes in with chest pain, you always want to keep that in the back of your mind. Anything else in the cardiac exam that stands out to you?
I think the fact that she doesn't have any notable murmurs and her heart sounds are normal, I think it indicates that it's more of a lung issue rather than a cardiac issue.
Good. So Dr. Ramirez is saying, can't that lead to tamponade? Do you want to elaborate on what you mean?
In the sense that she has a higher than normal heart rate and basically signaling that she has sinus tachycardia, which can't that also lead to cardiac tamponade?
It would depend if you have a buildup of fluid between the pericardium and the actual heart. So in the absence of pericarditis, so like if you don't have a friction rub on exam, they don't have positional chest pain, pericarditis is a little less likely. But if you did have those signs, then yeah, you would worry about tamponade, especially if their blood pressure was dropping. Okay, so Dr. Hoff. I think that's all I have for the, yeah. So Dr. Hoff, anything in the CBC stick out to you?
In the CV, I said, or there's no jugular vein distension, which means that the esophagus is lined up so the lungs aren't shifting. Let me know if I'm looking at the wrong spot.
So the labs. So in
the
CBC,
the labs. Sorry, I thought you said something else. So you mentioned earlier
okay.
that the white blood count is high, which immediately alludes to an infection somewhere in the body, and I would assume the lungs just from everything else.
Okay. So does an elevated white count always mean you have an infection?
Not always, but in this possible case, that's what I would focus on.
Okay, good. So if you have an elevated white count, you can have an infection. I definitely agree. Do you know of anything else that can cause an elevated white count?
I'm not really sure off the top of my head, but I know cancer.
Cancer, yeah. So like leukemia can definitely do it. Somebody had mentioned medications that she can be taking. Do you know of any medications that can cause that?
The hyperlipidemia medication she's been taking, and the high A1C.
Okay, so the medication she's taking, a lot of people have mentioned today that they can cause leukocytosis or elevated white count. I've actually never seen that, so that's something I'd probably have to look into. But steroids can cause elevated white count. So a lot of times when you have a pneumonia and you have trouble breathing, and let's say like your pneumonia is not getting better, you will start to give steroids because the steroids will decrease the inflammation within the lungs. People that die from pneumonia don't die from a bacterial infection most of the time. They're not dying from like fluid sepsis. They die because of acute respiratory distress syndrome or ARDS, which is also the reason why people are dying from COVID. So ARDS is how your body responds to that infection. So if there's an overwhelming response to that infection that's out of proportion to what your body should do, you have flash pulmonary edema where your lungs fill up with fluid and you can't breathe anymore. You're basically drowning yourself. And so we prevent that by giving steroids. And so if you have a patient that is not doing better initially on antibiotics and you start giving steroids and they're getting better, but their white count's going up, you shouldn't be worried about that as much. You shouldn't be worried about the white count as much because the steroids will increase that. So I hope that made sense. Okay, so Dr. Sarah Travers, anything in the metabolic panel stick out to you?
I think what stuck out to me in the metabolic panel was the CR. I forget what that stands for. Those levels were a little bit high, which could indicate that something may be going on with the kidneys. Sorry, can you hear me?
Sorry.
Oh, I said
Yeah,
I
I
think
can hear you.
because the levels are higher than normal, it could indicate that something's going on in the kidneys.
Yeah, so she has CKD though, so she has kidney disease. Why would if she has a baseline elevated creatinine, why would you be concerned about her creatinine now?
I'm not exactly sure.
Okay. So let's see, Sarah H, Dr. Sarah. Do you know if she has a baseline elevated creatinine, why would you worry about what her creatinine is right now?
That's a pretty big spike from her baseline. So I
And
think that
so-
could
so for-
indicate what, sorry?
Yeah. No, sorry.
I was just saying that could be indicative of the kidney disease that she also has.
Yeah, so if you have a baseline kidney problem and your levels are traditionally high, that doesn't mean that her kidneys are functioning at a reduced level, but now she has an additional insult to that. A lot of times we categorize kidney injuries based off of where the insult occurs. So either it's not getting enough blood, something's wrong inside the actual kidney itself, or there's a blockage after. And so, so if you're, for her, is it frozen for all of you guys? Let me see. Sorry about that. Is it still really choppy? Okay, so the audio is clear for now. We can go, and hopefully it'll get resolved. So if we know that she is dehydrated. So when you're dehydrated, you have less fluid going to the kidneys, and so that can cause a kidney injury. And a lot of times with sepsis or a septic picture, you can have that type of picture where you have a general increased creatinine because you have an additional kidney injury on top of your chronic one. So, sorry, I'm just gonna make note of the choppy audio or video. Okay, so Dr. Rena G. What do you make of the troponin? Okay, let's go to Dr. Aditi. What do you make of the troponin? Actually, let's go to Dr. Danny, since you answered. What do you make of the troponin? Can you guys hear me okay?
Hello?
Hey, so what do you make of the troponin?
Hi, so I just thought it was just slightly elevated. It wasn't too bad. Like, it could just be a problem further on down the line.
Okay. Okay, so Dr. Pearson, you're saying that it's not high enough to indicate an MI. Why is that?
I think I read somewhere levels of 0.4 and above usually indicate heart attack, and 0.07 is not much higher than 0.04. So that wouldn't really come to mind.
It's generally 0.04 and above indicate some type of cardiac injury. So she is elevated, but how do you know that this is not part, and how do you know it can be something else? let's go to Dr. Seisha. Can you tell us what you think of the troponin? Or Dr. Chelsea Manning?
Yeah, so I mean, I thought because it is elevated, it would possibly have a heart attack because she does have a history of coronary artery disease, so she is of a higher risk to have a heart attack. So I thought it was elevated enough to be a concern.
Yeah, so because of her history, she is at risk of having a heart attack. And so there you have to be able to distinguish, is this coming from the heart because the heart is dying, or is it coming from the heart because the heart is overworked? So that's the difference between a myocardial infarction and demand ischemia. And so if her heart is being overworked because of infection, like it looks like it might be here because she's tachycardic, or she's breathing fast, her oxygen sat is low, it would cause an elevated troponin, but that doesn't indicate an MI. So Dr. Ali, Vivian, what can you do if you're concerned that this might be a heart attack? What would you get after the troponin?
I'm not so sure. Maybe echocardiogram to see how the heart is.
So echo will show you, so if she's having an active heart attack, the echo can show you wall motion abnormalities, but even before an echo, there's something else you can get that can tell you if there is any signaling abnormalities within the heart.
EKG.
EKG, perfect. And so do you know what you would potentially see on EKG if she was having a heart attack?
Would it have to do with S5 and S6? But not so sure.
S5 and S6.
Like
the leads, you mean?
Yeah.
So you would have ST segment elevations if you were having a full-on heart attack, so a STEMI. You can have depressions or T-wave inversions as well. And so if you're concerned that this might be a heart attack, an EKG is a good way of seeing whether or not it is. And then what's something else you can do with the troponin if you want to make sure that she's not having an active heart attack?
I'm not so sure what you do after you get it.
It's okay. What about Dr. Thomas? Do you know what you would do?
I'm not sure as well.
It's okay. So if you were having a heart attack, let's say your troponin was 0.07 and you were having a heart attack, if you repeat the troponin, what do you think will happen? I think Justin's helping you out in the comments.
It's gonna get higher.
Yeah, so if you go from 0.07 to 6, you're having an MI and you need to go get that taken care of. But if it's 0.07, it goes to 0.08, or it stays at 0.07 or even goes down, that's not a heart attack. That's probably because of demand ischemia. Now, Dr. Fernandez, Emily Fernandez, what would you do if you did go to a troponin of 6?
Could you repeat the question? Sorry, my computer just froze.
It's okay. So let's say you went from a troponin of 0.07 to 6. What would you need to do at that time? And that patient's having chest pain.
So if it went to a 0.6 or 0.06?
No, if it went from 0.07 to 6.0.
Oh, so that means that they're definitely having, like, they need to go to, like, a cath lab or surgery or something because their like heart is dying at that point?
Yeah, they would go to a cath lab and you would do it emergently because time is myocardium at that point. So you have to put them to send them to a cath lab to get stented if that's possible. Good job. Okay, so so we saw the EKG show sinus tachycardia, and then and we kind of talked about the EKG. Now, Dr. Christina, can you? Last time I tried to show the X-ray, it froze. So we're not going to do that. But can you explain what you saw on the X-ray? Let's go to Dr. Niraj.
On the chest X-ray, you can see that there's some fluid in the lower right lung, which is
okay. Why do you say it's fluid?
Because it's like very fuzzy and indistinct.
Okay, so is that would you how would you be able to distinguish fluid between pus?
It's a good question.
It's it's hard. So if it's outside of the lung, if there's fluid outside of the lung, fluid tends to respond to gravity. So it'll settle to the bottom, and you'll see at the angle between the chest wall and the diaphragm, you'll see it a little bit more white because there's fluid sitting there. But on this chest X-ray, it looks like it's inside the lung. And so there's a haziness on that right lower side that tells us that there might be something there. And if you're ever not sure, especially because we haven't gone through chest X-rays yet, but if you're ever not sure on whether or not something is wrong on the chest X-ray should be symmetrical. So the lung fields should be symmetrical on both sides. So if you see something on the right side that's not necessarily there on the left side, that tells you there might be a process there going on. Now, it's a little complicated because on the left side there's a heart, but just ignore the heart for now. You see a little bit of haziness on that right lower side that's not present on the left. So that tells us there might be some sort of infiltrate in there, like an infection. So, okay. So let me see here. Doctor, I think I got most of you. Is there anybody I haven't called yet? Dr. Aaron, what do you think is going on with this patient?
I was thinking that it would be like pneumonia.
And why is that?
Just looking at her signs and symptoms, she has like shortness of breath. She has like trouble doing activities that she couldn't do before. So it's something that like came like acutely. She's been coughing, has a sore throat. I don't know, a lot of her signs just like point to a respiratory infection.
Yeah. So she's short of breath. She has chest pain. She has findings on the chest X-ray that look like a pneumonia. She has signs of sepsis. So when we're talking about the difference between finding a source, this would be finding the source. You're able to actually see the pneumonia that's causing that inflammatory response. And so her source would be that pneumonia. She has findings on the physical exam indicative of pneumonia. The increased work of breathing, the crackles in that right lung field. There's something called egophony. Does anybody know what that is? And it's okay if you don't, because I don't expect any of you to know what it is. Okay, so egophony is a change in sound. So when you listen to the lungs, if you ask the patient to say E, and they keep saying E, 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 when you listen to it with the stethoscope, it'll sound like an A. So that's the E to A sound. So you listen to it, they say E, it sounds like A. And it's because of the way that the sound is transmitted through that consolidation within the lung. Because the sound waves change as they propagate through something more solid as compared to something more hollow, like the air in the lungs. And so that is a good way of trying to see if something is, if there is a a consolidation like a pneumonia. The other thing you can do is tap on the back, and if it goes, if it sounds more hollow and it goes to more dull, that tells you also that there might be something there. Good. Dr. Deepika Bhatia, is there anything else that your team was considering?
We initially thought that it might be pericarditis, but because of the way that it was, like she was coughing and like having chest pain, so we kind of thought there might be inflammation there. But we kind of, well, now like going through this, it doesn't obviously seem like it's pericarditis because of the fact that there's not necessarily a frictional rub sound. It's more like crackling. And also, if you look at the EKG, I remember you mentioned in the video that if it was pericarditis, they would be diffuse ST elevations, and it doesn't mention that either.
Perfect. So what we did here is basically what we do in the hospital. We look through the case and we try to pick out things that make diagnoses more likely and less likely. So all of you have different levels of expertise and experience, and for me it's really amazing to see people with no formal medical training being able to pick out and distinguish a diagnosis. So you guys should all be very, very proud of yourselves. You guys did a really, really good job. Dr. Ono had asked before, why do you get fluid buildup with ARDS? So in ARDS, because you have that systemic overwhelming inflammatory response, when you have inflammation, your vessels dilate. And so as you dilate, your capillaries and the vessels become very leaky. And so as they become leaky, you start spilling fluid out into the surrounding tissues. And so if all of your vessels become leaky and you're spilling fluid out, well, now you're just pouring fluid into your lungs. And so in ARDS, you have fluid overload because of that inflammation causing buildup of fluid in the lungs. And so the way to get rid of that, or to try to prevent death, is to decrease the inflammation, usually using steroids. So I hope that answered your question, Dr. Ono. Is there any more questions that you guys had? I hope this was helpful and stimulating to some extent. Next week, we're going to have another case on chest pain, but you're not going to know what the actual chief complaint is. I also realized that my chat did not scroll, so I missed out on a lot of your comments. So if I didn't answer something that was there that you guys had commented, comment again and I can answer it. Okay, so perfect. So Dr. Girish had mentioned, can it be an aspiration pneumonia? So Dr. Girish, do you want to talk about why you think it might have been aspiration pneumonia as opposed to community-acquired pneumonia?
I was just thinking because she has a history of dementia, and I know dementia, people diagnosed with dementia usually die of aspiration pneumonia. So that was just something that I was thinking about, could be because of that.
Yeah, so what causes an aspiration pneumonia?
It's like, I think it's like when food or something or water goes, it doesn't go through the esophagus, it goes into the windpipe, and then because of that, the bacteria from like your mouth kind of just causes a whole infection. And yeah, I think.
yeah, good job. Yeah, good job. So I'm just reading through some of the comments. So yeah, basically, patients with dementia, you will aspirate on your food contents. You will basically, instead of going through your esophagus, you go into your lungs, and the bacteria in your mouth start to seed into the lungs. And so it's a different treatment protocol for what antibiotics you would typically use, because you have to cover the mouth flora as well. Can you go over the differences in symptoms between pneumonia and pulmonary embolism? Is fluid in the lungs more indicative of pneumonia? Kevin, since you said that you didn't go, and I don't think I called on you, can you answer that question? Sorry to put you on the spot.
Sorry, can you repeat the question?
Yeah, I can hear you.
Sorry, can you repeat the question?
So the question was, what's the difference between a pneumonia and a pulmonary embolism? So what signs do you
audio
typically
is
see?
lagging a bit, so I can't really hear you very well. What do you think?
So what is the difference between the pneumonia and a pulmonary embolism?
For pulmonary embolism, it's more. For a pulmonary embolism, it's like a blood clot in the lungs. So typically, you have a higher buildup of platelets and white blood count. So that's what I initially thought it would be, rather than pneumonia, because even though you can get a dry cough from pneumonia, which is more atypical, it's you don't have the same like fluid buildup, I guess, in the lungs.
Okay. So exactly. So the so with a pneumonia though, in elderly patients, a lot of times you will have a non-productive cough, and they can also not even mount a fever. So that's why with elderly patients, you always have to have like a higher level of suspicion for things that are potentially more dangerous. But yeah, definitely good job. And is fluid in the lungs more indicative of pneumonia or pulmonary embolism?
I guess it'd be more pneumonia in that case.
Yeah, and it's not necessarily fluid in the lungs. It's more of an inflammatory process, and it's more consolidation of like infected lung tissue. Good job. Let me see here. If it was pulmonary edema, would the chest X-ray be bilateral, or how would you differentiate between that? Is there anybody else that didn't call on? Dr. Roshni, do you want to take that question?
Can you repeat the question?
So, yeah, so if it was pulmonary edema, would the chest X-ray be bilateral, or how would we differentiate between pulmonary edema and pneumonia?
I think for pulmonary edema, I don't know that it would be bilateral, but I feel like the fluid wouldn't look as diffuse as it does in this chest X-ray. It might be a little bit more like more opaque rather and more settled rather than what we see here. I don't know if that's correct.
So I think you had it the opposite. So with pulmonary edema, you get pulmonary edema because the heart can't push fluid forward. And so when it can't push fluid forward, it backs up into the lungs. And so it won't back up into one specific lung. It'll back up bilaterally. And so you will see both lungs have some like hazy opacities at the bottom. And you can also look at the vessels, and we'll go over this on the X-ray video. You'll see the vessels going up to be a little thicker. So that's how you would typically differentiate it.
Okay.
So Dr. Verma was saying that their group is considering CHF. Is it still a possibility? And yes, it is. But it would be that same thing that you would typically see pulmonary edema with CHF. And you would typically have some swelling in the lower extremities, and you'd have some jugular venous distension as well, because that fluid is all building up. And the typical signs of congestive heart failure is not so much chest pain, but you would have shortness of breath as you are trying to exercise. So if somebody came in and said, "Doc, I used to walk 3 miles and now I can only walk a block before I get short of breath," but they have no chest pain, then that's more indicative of congestive heart failure, because the fluid that backs up into the lungs doesn't allow for good oxygen transfer. And so you don't necessarily have pain because the heart tissue isn't dying. It's more shortness of breath. And so I hope that makes sense. So was the anosmia caused by pneumonia? No, it wasn't. The anosmia, I said that the patient denied all those symptoms. So I apologize because I wrote DENES instead of denies. So all of those symptoms that I had listed, she denied. How do we rule out angina? Angina is more of a clinical symptom. So, and it's that chest pain that gets worse with exercise and activity. So if the patient is telling you that I am walking and I'm getting short of breath and I have chest pain, but after that, after I rest, it gets better, those are typical symptoms of angina. It won't necessarily rule it out completely. You still want to do tests, and you'd probably end up doing a cardiac stress test, but that's one way to tell if angina is more likely versus other possibilities. Any other questions or any other? Okay, so how did we completely rule out pericarditis, or what would we have seen on the echo? So pericarditis was less likely because the patient did not have positional chest pain. They didn't have that friction rub. They didn't have diffuse ST elevations. But if we were to get an echo, we would usually see thickening of the pericardium as a sign of inflammation, and you can see a little bit of fluid between the pericardium and the heart, which is a pericardial effusion. If that effusion is large, that causes tamponade. But in this case, I don't know why they actually got the echo. I was a little confused with that as well, but I just put it in to keep it a little bit more consistent. I don't know if I would have gotten an echo. Yeah. Okay. Any other questions? It's an adapted case. Yeah. So the cases that I am presenting here, they are based off of real cases, but a lot of the information was changed so that we can protect patient privacy. How did we rule out angina? I think I had already mentioned that. So how do we rule out kidney failure? So kidney failure, so in this case, it wasn't kidney failure, it was a kidney injury. So kidney failure, when you have kidney failure, the functions of the kidney are impaired. So you're going to have electrolyte abnormalities because you're not able to properly filter the kidneys, filter the electrolytes and the toxins. The other thing is that you can have uremia, so your BUN is going to be very high because that's another product that's filtered by the kidneys. There's a whole mnemonic that I'm forgetting right now, but I can post it. If you leave it in the comments, I'll post the whole criteria of kidney failure and how you decide if you need dialysis or whatever. Would I admit this patient? Definitely, I would admit this patient because she is septic, and so the vitals show us that she is in sepsis, and so I would want to give her fluids. I'd probably want to give her IV antibiotics at first to make sure she's doing better. Typically, for a community-acquired pneumonia, I would do ceftriaxone, maybe azithromycin. But for her, because I would maybe be suspicious of a aspiration event, I would consider Unison, which is amoxicillin, clavulanic acid. So, and we'll go over antibiotics in the future. Okay, so angina, it's less likely angina because she doesn't have exertional chest pain. She's not exercising and she's not getting chest pain after that. And her chest pain is not getting better after she rests. And so those are the typical symptoms of angina. And so because her history is more consistent with something else, I would make angina lower on my differential diagnosis. I wouldn't rule it out completely, especially because her troponin was a little elevated, but we have a good reason for it. And so in medicine, a lot of it is your pre-test probability. How likely is it that this specific problem is going on versus another problem? And so looking at her picture, because she has this infiltrate, because she looks infected, because she has these lung findings, I think pneumonia is more likely, and I would treat that first. I would still get the troponin, I would get an EKG and all that, make sure that there was no cardiac issue, but after that, I would focus more on the pneumonia. The fact that she has sharp pain instead of discomfort doesn't rule out angina because, again, people can have a bunch of different symptoms and still have angina or cardiac issues because there is the typical definition of chest pain because of a heart issue, but it's not consistent with everybody. Why are patients with dementia more likely to get an aspiration pneumonia? So as your dementia progresses, you have a harder time controlling your secretions and controlling how you swallow. And so a lot of times with that, like if you can't protect your airway and you swallow food or water or something and it goes into your lungs, you aspirate on that substance and it can cause that infection. Okay. Any other questions? You can either leave them on the YouTube or you can put them in your classroom and I will try to answer them. I hope this was fun. I hope you guys learned a lot. You guys should be very proud of yourselves for what you did today. It's amazing that you're able to figure out this case with your team. Next week is going to be a little bit more interesting, and I'm excited to see how you guys do. Okay. Have a good day, guys. Stay safe. I will talk to you guys soon. Bye.
Thank you.
No problem.